Health
Yeah.
Organization.
It-
Sometimes the words just don't come
I tell
out.
you
I
what.
understand it.
So, the World Health Organization says that African countries are making important progress in tracking their health workforce. Information that is crucial for knowing where doctors, nurses, and other health workers are needed most. 10 of the 20 countries globally with the most recent and complete health workforce data are in the WHO Africa region, with Zambia, Burkina Faso, and Kenya among the top performers. To discuss what this means for healthcare across the continent, we're now joined live by Dr. James Avoka Asamani, who's a regional advisor on health workforce at the WHO Regional Office for Africa. A very good morning to you, and thank you so much indeed for joining us.
I think you have the wrong name.
My apologies.
This is Dr. Adelaide Onyango, the Director of Health Systems and Services at the WHO Regional Office for
Thank you so,
Africa.
so much for correcting me. I've got the
Yes.
wrong script in front of me at the moment, but thank you so
No,
much
no,
indeed for
James,
that.
James delegated upwards.
Okay, it's good to have a junior staff delegating upwards.
No, he's not junior at
I
all. He
mean,
just delegates.
yes. All right. Well, thanks so much
All
indeed,
right.
Adelaide. Well, let's start with the big picture then. What does it mean for Africa that 10 out of 20 countries with the most complete and recent health workforce data are actually from Africa?
Well, what that means is that, first of all, we need to understand from the outset that this does not say that we are doing perfectly well in terms of health workforce supplies and scaling. It simply means that we are standing up to be counted in terms of having the information that is needed for us to understand where we stand with regard to our health workforce. Who do we have? What qualifications do we have? Are they enough? Where are they placed? And are they supplying the needs of the healthcare system?
Zambia, Burkina Faso, and Kenya, they seem to be leading on the African rankings. What are they doing particularly well, do you think?
Okay, so what they're doing well is that they are making available the information that is needed for us to understand where they stand. So it's not about the health workforce adequacy or the quality of care. It's really just about they're able to tell us where the needs are, where the professionals are, and where efforts need to be made to fill the gaps. This means that they draw together information from multiple sources, including professional registries, payrolls, training records, administrative systems, and they're able to therefore tell us in real time that we do need so many health workers in these different places. The Zambia and Kenya have conducted health labor market analysis, which helps them to connect data on workforce supply with education, employment, and the population health needs.
I think you may have answered my next question already, actually, which is why, have accurate information on where health workers are, and why does this matter to the actual patients?
Yeah, it matters to them because then you know where to go and look for what type of care. When patients know where the specialists are, when the people referring patients also know where to refer them to, then it makes healthcare services much better available than if we are unaware who is where to provide what type of care. So really, we can say that the having data, having the workforce data is not an administrative requirement. It is really the foundation for equitable patient care.
And I suppose if the authorities have this data and have this information, it can help them make decisions about training, recruitment, and deployment.
Exactly, because when they have this information, they can answer the questions: how many health workers are needed, how many are being trained, preparing the pipeline, and how many can be funded and employed, because that's a critical part of completing the cycle of planning, training, and recruiting and retaining, especially the retaining. So you see, what the National Health Workforce Account does is to bring together the registries on education, payroll, vacancies, expenditure, and complemented by health labor market analysis. They examine relationships between uh, what what are the population needs, and therefore what must we do in order to answer for those needs in terms of educating and putting together the funds that are needed for them to be employed. We also use in that process workload-based tools to identify staffing requirements. So if people, there may be health workers in a given place, but the demand is very high. So if they are overloaded, then we need to know that we need to plan also for augmenting the services that are understaffed.
Knowing and doing are not often the same thing. And I just wonder, are you seeing examples of where there's good data collection translating into good policy, good decisions that we've just discussed?
Yes, indeed. We have some of these countries that are showing up. I won't give you the names right now because I may miss out somebody that has done the very best. But precisely this is the fundamental information that is needed for the countries to be able to then understand where they need to invest. And actually, going from the analysis to then being able to influence policies is a very important part of the work that is being done as part of the Africa Health Workforce Investment Charter. And we've seen, let me cite one example of a country like Zimbabwe, which, because they have gone through these processes, have been able to increase their health workforce by actually government investing and having all the partners that come together on the investment charter invest in the same thing. So we bring together the planning and the investments. Zimbabwe has done that. We have seen an increase in health workforce recruitments in Kenya as well. And there'll be other countries. I said I wasn't going to name names, but some of them do come to mind.
I suppose it gives us indications of leakages as well, because we know that a lot of our healthcare providers are sadly leaving the continent and finding themselves in other parts of the world. This
Yeah.
data will track that kind of leakage, and perhaps we find policies of how do we retain certain types of healthcare providers because they seem to be leaving more in their numbers.
Yeah, exactly. In fact, we did a 12-country in-depth analysis of not just the numbers that are there, but the satisfaction. And it was a very informative exercise because based on that, the countries like Ghana have been able to understand what they need to plan for and the incentives that they need to put in place so that the health workers that have been trained in the countries are not being lost, especially those who are employable. Because, of course, it also helps us to understand that we are at high risk when the health workforce that we train, the best among them, the most experienced among them, are the ones that are being targeted for foreign markets. And that has informed for certain countries their discussions, like the negotiations with the importing countries to understand how they can get something back, because we have invested in the training as rather low income countries, and yet we are exporting to countries that should be able to train their own. So those negotiations among countries are very well informed when we know how many of our workers we are losing to the foreign markets.
I mean, it's a good story of progress, but I would imagine that there are still some significant gaps in health workforce data across the continent. Give us some clues of where some of the challenges remain.
Yeah, yeah. I would say one of the greatest challenges is the fragmentation because the relevant information is often held in separate ministries. The Ministry of Health knows, they have so many workers in different cadres, but education is the one that's responsible for training of the different specialties, and they may not have registries that are actually linked. Then we have the public service and finance, the regulatory councils who know what the qualified and what level of qualification they have in their health workforce cadres, the training institutions, the employers, and the private sector. So we have very many fragmented pieces of information that need to come together for us to get a comprehensive picture of who is available, what are they doing, how many do we need, and can we afford the numbers that we need? How do we incentivize where they go? Because we also understand that if we do not have complete information on, for example, the areas that are underserved, then we are not able to address the inequities that are a serious problem. We also have issues such as the incompatibility of information systems, because sometimes we have registries that can't even speak to each other. Occupational definitions are not always the same even within the same country, and we depend in some cases on externally funded data exercises. So the information on the health workers that we have may actually not be in the hands of the government and those who need to do the planning. So that fragmentation and the incompleteness of information are very important gaps.
All right, and perhaps briefly, looking ahead, what would you like to see African governments doing differently with their health workforce data over the next few years?
I think it's very important that governments institutionalize and sustainably finance the health workforce information systems, because that is where we're going to understand what we have and what we need. And it is important also that this is an exercise that is multisectoral. So in a sense, confederating, bringing together those different sectors that are responsible for the consumption in terms of the use of the health workers that are trained, but also the training, the financing. Because if it's not done as a whole of government exercise, then we are going to struggle with the different areas, the different sectors, training or needing what they cannot bring together, what they cannot actually deliver for the care of the populations. It's also important that governments diversify and integrate their data sources rather than relying on single registries or on surveys. Sometimes we conduct these surveys, but those surveys don't translate. It's important that once we have gotten these information, these data together, we use that information to really advocate, to explain why it is very important for us to invest and to train and to deploy in areas where we can fill gaps and, for example, avoid the high costs of seeking care abroad or simply not being able to provide the care. And I would also say that especially now that we are, this week we are holding our exercise with different countries on national health workforce accounts, it's also an opportunity for governments to learn to do this south-to-south learning, because then we understand, we can look at what other countries have done and say, okay, you had a challenge with deploying to rural areas. What incentives have you used? So that cross-learning is an important part of what governments can do for one another so that we move together forward as a region.
That's where we're going to have to leave it. Dr. Adelaide, thank you so much indeed for joining us and giving us some powerful insights on this important data. Thanks for your time.
Thank you very much and have an excellent day.
That was Dr. Adelaide Onyongo, Director of Health Systems and Services at the WHO Regional Office for Africa.
The sound of Africa.